Hello.
Hello.
Hello. Hi, sir. Good evening.
Good evening.
I have made you the co-host, sir, and you can share the screen.
Okay. Okay. So, hi everyone. Welcome again to this session. So, as yesterday we started with the head and neck and we did the osteology part. Today we're continuing from there. We'll come to the other parts of the head and neck. Right. I'm Dr. Ankit, your anatomy educator over here in our Auricle platform, and this is the exam master live classes. The topics which is going on right now is the head and neck topic. And this is beneficial for not just for the university exams, but even I'll give you some important points which are going to directly help you in your FMG or your NEET PG exams and all that, right? So be prepared for that, right? Okay. Fair enough. Let us see some of the slides here. So the topics that we are going to cover today are mainly related to scalp and the face. These are the main long questions, long essay questions, which mainly come from the scalp as well as the face part, right? And it's related short questions are also which we are going to cover today. Okay, so short answer questions like this. We have black eye, we have dangerous area of face, NLDs and all. And core features of Oracle, you can look from live classes, recorded notes and MCQs, that's all we have. And few subscription plans are also there, right? From basic plan to the mentorship plan, from 15K to 50K in between. We have the standard plan for 6 months. So basic for 3, standard for 6, and mentorship for 12 months, right? From 15K to 50K we have, right? Okay, last but not the least, you can use this code also, Dr. Ankit 20 for discounts on any of the subscriptions which you are planning to get it, right? Okay, so that was a brief introduction. Let us move straight away to a point, and that is the topic over here, which is the head and neck part, right? So basically dealing with the scalp topic today. Okay, so scalp and face are the major topics, and with that we'll cover up the other topics related to those two topics. Okay, so let's start now. So scalp, first of all, basic meaning of the scalp. So what is the scalp over here? The scalp is nothing but the soft tissue which covers the cranial vault forms the scalp, right? So we have this scalp hairs, right? This hairs over here on the head. The skin over here, right? It is different from the skin elsewhere. If you look at the entire body skin, trunk, right, face, hand, upper limb, lower limb, the skin over the scalp is a bit, the skin over the head is a bit different, and it is regarded as what we call it as a scalp over here. So it's a soft tissue that covers the cranial wall. Now, first of all, from where to where does it lie? Because anatomy is actually fixed in many in extent wise. If we talk, then anatomy is fixed over there. So we should know the extent of the topic. So scalp anteriorly starts from supraorbital margin. So right from here, this forehead is not just a part of face, but this forehead is also a part of the scalp. So anteriorly we have the supraorbital margin from where the scalp starts, and posteriorly we have the external occipital protuberance, which we discussed yesterday, right? External occipital protuberance. So from here to here, from supraorbital margin to external occipital protuberance, we have the scalp. And on the sides, we have this temporal lines where we have the temporal fascia attachment. On the sides, we have the temporal lines where the scalp, the boundaries of the extent of scalp. So you should know these three terms at least. This is actually basic. See, what happens is whenever we read any topic, no, in any subject, we go to the depth of it and then we lose the basic idea of the topic. So remember, scalp is from supraorbital margin to external occipital protuberance on the sides to superior temporal line. That is enough. Now come to what actually is the scalp made up of. Core and out with the scalp. So scalp has 5 layers, and mnemonic is also scalp. So this is the one of the rare things in anatomy you can easily learn it, right? So scalp itself has 5 layers. The mnemonic has been made up. That is our SCLP. Scalp is the mnemonic for it, right? Let us see what this mnemonic tells us. So first of all, S is the outermost. So you are going from outermost layer to the deeper layer. So there are actually 5 layers in the scalp. Outermost is the skin, which you can easily feel it. You have the skin, which is having this sebaceous glands and all that. Then C is for the connective tissue. C is for the connective tissue. Beneath the skin, you have the connective tissue. Now, this connective tissue it is a bit dense. Okay, it's a bit dense, so I'm just writing D in brackets over here. Then comes A is for aponeurosis. A is what? A is for aponeurosis. Okay. What do you mean by aponeurosis? By aponeurosis, we mean that aponeurosis is flattened tendon. It is a flat tendon. Okay, so suppose there is a tendon, you have seen the tendon, muscle tendons, and the tendon is crushed, right? There is a like a 1,000 kg weight placed over tendon, or more than that, so that tendon is crushed. So now it is a flat, right? That flat tendon is known as aponeurosis. So A is aponeurosis. So here you don't feel any tendons in the scalp, but yeah, there's a flattened tendon over here. L over here is the loose areolar tissue. It is a loose areola, again a sort of connective tissue, but slightly loose. Okay. And P over here is the covering of the bone because the deepest part will be the bone. This whole scalp is sitting over the bone. Which bone? The skull bones, frontal, parietal, occipital, temporal, right? So the deepest part is the bone, but bone is not a part of the scalp. So P over here is covering the bone, so it is known as the periosteum or also known as pericranium. Periosteum or pericranium. Okay, understand this part. These are the 5 layers. These are 5 layers. I repeat again. S for skin, C for connective tissue. This is the real connective tissue, or the dense connective tissue. A is the aponeurosis. Actually we have a muscle known as occipitofrontalis, right? So we have a muscle over here that is known as occipitofrontalis. Let me write its name also. Occipitofrontalis. Now this name itself is sufficient. You can easily understand this muscle is from where to where. It is from occipital bone to frontal bone. You have occipitofrontalis. So muscles are over here. Muscle belly that is present over here, frontal as well as occipital, and between over here in the scalp, we have the flattened tendon, right? L is the loose areolar, P is the pericranium. Now, see, if you place your finger over this over your head like this, right, and you try to move, can see there's some movement, right? There's some movement over here. Okay, there's some movement of the skin, right? You try to move it because we have underlying bony structure, so we can move it, right? Now, when you are moving the scalp layers, it is actually these 3 layers. Which layers? These 3 layers, S, C, and A, S, C, and A, skin connective tissue and aponeurosis, which are actually moving over the deeper lying loose areolar tissue and the pericranium. Understand that part. When you're moving over here, it is these 3 layers which are moving over loose. So loose areolar forms a smooth bed over which the skin and the related structures can easily move. Understand this. Okay, right. This is the basic information I'm giving. Let us will go into a bit of detail over here. So understood the 5 layers, SCLP. Okay, and muscle also name occipitofrontalis. Let's see each part. So skin over here, points. I'm highlighting the important points over here. The skin is hairy, we all know. Right? Skin is hairy. It is adherent to the aponeurosis through the dense superficial fascia. Now, this dense superficial fascia, which they are saying over here, there's nothing but that C, that is a connective tissue. So skin is attached to the aponeurosis via the connective tissue. The connective tissue name is it is connecting skin to aponeurosis. Simple as that. Okay. So skin is hairy, it is either and fine. It has more number of sweat glands and sebaceous glands. So whenever you are going out in a this environment where it's very hot and humid, there's a lot of sweating over not just over the face but also over the scalp. Suppose you are wearing a hat. Okay, you are wearing a tight hat. It's quite sunny out there. So once you remove the head becomes wet with the sweat over there. Sweat is coming from the scalp only. Understand that. So there's a lot of sweat in sebaceous glands. Well, there are a lot of hair follicles. If sebaceous glands also, that's common sense. So we have a lot of sweat in sebaceous glands in the skin layer only. Let's see the next layer, that is superficial fascia. This is the same as connective tissue layer. S, this was S over here. This is now C over here. Now for the connective tissue, it is more fibrous and dense in the center than the periphery. Remember, it is fibrous and dense. It contains many blood vessels. That is a feature of all the connective tissue in our body. It binds the skin to the aponeurosis and provides a proper medium of passage of vessels. Fine. So understand the most important point over here. Let me tell you, the for connective tissue is that it is very fibrous. Now, connective tissue is fibrous. What does it mean? I'll give you a practical example over here. Listen very carefully. If a person becomes overweight, right? There's a fat accumulation in various parts of the body or nearly all the parts of the body, except scalp, except your palm of the hand. and except sole of the foot. These are the 3-4 areas where there is minimal accumulation of fat. The reason is that the connective tissue is very fibrous. So just imagine for a second that if suppose this is the connective tissue, right? This connective tissue will be having what? Will be having some blood vessels, right? Will be having some veins over here. Will also be having some nerves lying over here. And also it is going to be a lot fibrous. So when the connective tissue is very fibrous, there is very less space for fat to accumulate, right? So if you look at a very overweight person, obese, morbidly obese, BMI 40, 45, BMI 50 even, weight of say 140, 150 kgs, people are there. We'll see very less accumulation of fat over the scalp, over the palm of the hand. While other areas, obviously, there's accumulation of. Now, this is one reason over here. This is the anatomical reason of this, why there is less accumulation of fat. Okay, this is one anatomical reason. Okay. Okay, so it is more fibrous and dense. Fine. So this superficial fascia or connective tissue over here. SC, then comes A. Then comes A over here. A is this aponeurotic layer, which is also known as galea aponeurotica. So it is freely movable on the pericranium along with the overlying adherent. So as I told you, when you are moving the scalp, these three layers are the ones which are moving: skin, connective tissue, and aponeurotic layer. Anteriorly, which muscle we have? We have the frontalis, and posteriorly we have the occipitalis. So it is known as occipitofrontalis. Muscle was known as occipitofrontalis. And these are the attachments of the muscle. Again, the attachment of the muscle will be same as the attachment of the scalp. Now here, let me tell you, we'll come on later also, but if someone asks you what is the nerve supply of this muscle, occipitofrontalis, which nerve is the motor supply? And the nerve over here is the seventh or the facial nerve. Seventh or the facial nerve. Remember this. Okay. So SCA done. Now comes the loose areolar. So that is the L over here. It is made up of loose areolar tissue. Fair enough, right? Anteriorly attached where? Anteriorly attached into the eyelids. Now, very important point over here. That is anteriorly attached to eyelid. Eyelids over here. Upper eyelid basically. So this loose areolar is attached to eyelid anteriorly, and posteriorly it is attached to the bony part. So understand over here that this loose areolar, not just this loose areolar, but if we look over here at the frontalis anteriorly, this frontalis is also going to the upper eyelid, okay, and behind it is attaching to the bones over here. Same for the loose areolar, anteriorly it is going to the upper eyelid along with the aponeurotic, or we can say the frontalis muscle. So see what is actually happening. I'll give you a clinical perspective out of it. That anteriorly, we have the muscle and the loose areolar attaching to the eyelid. Behind and on the sides, these layers are attached to the bones directly. So they are sort of fixed over here because they are attached to the bones. Anteriorly, this eyelid, you can see this skin is very loose, right? The skin is very loose. So what happens? It gives us clinical situation which you all must be knowing or must have heard about, the black eye. Suppose there's some injury over the scalp, right? And there is some bleeding which is happening below the aponeurotic layer, that is between the aponeurotic and loose areola. Suppose these two layers we are studying, and just for a second, if you can believe in this manner, that there is some bleeding over here. Okay, above we have the aponeurotic, below we have the loose areola. So this bleeding over here will slowly trickle down and will accumulate around the eyelids. That situation is known as the black eye. I'll show you the image later on. First, we'll complete the theory part. I'll show the image later on, right? Let me just wait for a second. Let me try to show you the image over here. Just give me 1 second, right? Of the black eye as we were discussing. Let us see the image of the black eye. Here it is. So yeah, here it is. Right. So you can see over here, this part over here. Okay, you can see around the whole eye. This is the injury is not happening over here. The injury did not happen directly over here. The injury happened somewhere in the scalp, and slowly the blood trickled down. You can see on the right side over here as well, on the left side over here as well, and it accumulated around over here. This is the anatomical reason why it happens. Okay, if you're getting the point, this is the anatomical reason of why it happens, right? So attachment of aponeurosis and your loose areolar tissue. Second thing over here about the loose areolar, let me tell you in one word that this loose areolar tissue layer It is a dangerous layer of scalp. It is the dangerous layer of scalp of frequently asked questions of MCQ or whatever type you can say. Why? The reason, the answer for that why is that it gives passage to what? It gives passage to the emissary veins, right? Which connect the extracranial veins to intracranial venous sinuses. Therefore, any infection around the loose areola, and if the infection passes through the emissary veins in the loose areolar layer, they might go into the meningeal, okay, that is inside the skull. Meningitis, encephalitis might be a complication. Therefore, loose areolar layer is regarded as the dangerous layer of scalp, the dangerous layer of scalp. Finally, we have the P for pericranium, right? Finally, we have the P for pericranium. It is covering the bones known as pericranium, but understand over here, and I'll tell this clinical implication as well. It is firmly adherent to sutures where the suture ligaments are there. Okay. Now I'll tell. Here's an image, but before looking at the image, let us understand what is the clinical implication of this line that the pericranium is firmly adherent to the sutures, and what is the clinical implication of it, right? So if I try to show you that, okay, this is a bone and a suture, this is another bone, right? Some bones of the skull. So these are the sutures. These are what? These are our sutures. Okay. Here we have this as the pericranium. What is this? This is the pericranium, right? Now this pericranium is loosely attached to the surface of bones, but it is firmly attached. Suppose it merges or mixes over here with the sutural ligaments, okay, like this. Now what will happen? Try to understand. Suppose there is a bleeding which is deep to pericranium but superficial to bone. Suppose there's a red color over here. I'll show you some. Suppose there's a bleeding over here. This bleeding is between what? It is between the pericranium and this bone of the skull, right? So now this blood over here, if it starts to bleed more and more and more, this bleeding will only be limited to this bone only because it can't cross the sutures. It can't cross the sutures. So the bleeding over here, that is the bleeding which is deep to pericranium. Okay, the subpericranial bleed over here will be limited to one bone only. It won't cross the sutures. While in the previous case, as we were discussing that, okay, if there is a bleeding which is in the loose areolar layer where it went to the even the upper eyelid, so that is loosely over here, the blood can easily go places, and it went to upper eyelid, leading to black eye, right? So bleeding which occurred in the subeponeurotic layer, where in the subeponeurotic, that is just beneath the aponeurosis, bleeding in the subeponeurotic layer can lead to black eye. But if the bleeding is between the bone and the pericranium, that bleeding will only be limited to one particular one because the pericranium anatomically is firmly adherent to the sutures via the sutural ligaments. That's the whole thing. This clinical situation is seen when a child is born in a normal delivery. We have conditions like cephal hematoma and scapula succedaneum. Let me show you that image also. Okay, so what we are seeing over here, let me show you that image. Here it goes. Here it goes. Now have a look at it. What we were discussing over here. Now see. Right over here. See, in this image over here, in the on the right side of your screen, you see the big bulge over here. Here the bleeding is superficial to pericranium, so it is subeponeurotic. So it is going across the sutures. This condition is known as caput succedaneum. Caput succedaneum. Okay. While this on the left side of the screen, you can see this bleeding over here is limited to one particular bone only, and this is known as cephal hematoma. Cephal hematoma. Okay, so anatomically wise, it is deep to pericranium. This bleeding over here, it is deep to pericranium. It is in the scalp only, but it is deep to pericranium. Anatomical wise, caput succedaneum, this is nothing but subaponeurotic bleed, or this is bleeding in the loose areolar around that part. So it is not going below the pericranium. Okay. This is the point over here. So do remember this. Okay, let us see more over. So these are the 5 layers of scalp. I hope the point is clear. Let us move ahead. So now, there's also a region known as superficial temporal region. Sometimes a question might come from here. Okay, we'll come to the more parts of scalp, but this is a small topic over here. The superficial temporal region, first understand practically. Yesterday we discussed about zygomatic arch, right? This zygomatic arch, right in front of tragus, you feel a very hard, bony ridge over here, right? Right? That is zygomatic arch. Now, this area is the temporal bone. We have the temporal lines over here. And as I told you that we have this cavity over here is actually filled by fascia and muscles. This region, which is between the superior temporal line and the zygomatic arch, this is known as superficial temporal region. And it has few layers. Obviously, outside we have skin and fascia. Then, as we discussed that, okay, epinosis is coming over here only, but its extension might go to the ear muscles or muscles of auricle. Now, muscles of auricle, this auricle is not our auricle platform over here, but auricle means pinna over here, right? So, in not in humans, but in lower animals, this ear movement is very important, right? This ear movement because a lot of flies will come and they sit over here. The lower animals have huge ears. They flip it around. It's for the your heat regulation also. That's very important. So they move the auricle a lot. So the muscles of auricle are very important. They're known as auricularis anterior, auricularis posterior, auricularis superioris, all that. Then apart from skin, fascia, and the muscles, we have the temporal fascia and temporalis muscle. Now this temporalis muscle is not a muscle of the face, it is a muscle of mastication. We'll see in the muscle of mastication over here. And finally, we have pericranium. So these are the regions of superficial temporal region, and these are the layers of the superficial temporal region. Do remember that. Okay. Now let us see more about the arterial supply over here. So we have seen the anatomy of the scalp, basic idea, what are the layers. Now let us dive a little bit more into it. So what are the arterial supply? What is the arterial supply of the scalp? Because the scalp, you know that a small injury over here and you see a small swelling. A small cut over here, a lot of bleeding. So scalp is having a very rich blood supply in front of auricle. So this is the level, you can say this is the auricle over here. This is the level. In front of auricle, you have these three main arteries, supratrochlear, supraorbital, and superficial temporal artery. Remember over here that they are the branches of both internal carotid and external carotid artery. The superficial temporal over here, which you can palpate actually. If you put your finger right in front of the ear, wait a few seconds, you will feel a palpation. You feel a pulsation, and that pulsation, that artery is superficial temporal artery. It's a branch of axon carotid. Now these over here these arteries are coming from here. These are supratrochlear more medially and supraorbital more laterally. These are branches of ophthalmic artery, which in itself is a branch of internal carotid artery. So internal carotid artery branches and axon carotid artery over here. While behind the auricle, that is in this posterior part of scalp, this behind the auricle means basically posterior scalp. Posterior scalp. You have two arteries, posterior auricular and occipital artery. Both are branches of action carotid artery. Right. So remember this arterial supply. Okay. Let me show you another image. Okay, showing us the arterial supply. Okay, here we go. Let me just zoom it a bit, make it full screen. Yeah. Okay. So on one side over here, we are looking at a arterial supply. Arterial supply. You can see over here, this is the anterior view. You can see the nose, and below you have the posterior view. This is the auricle over here. So in front you have supraorbital, supratrochlear branches of internal carotid. Then you have the superficial temporal in front of auricle, and this postauricular and occipital, all are branches of external carotid artery. Similarly here, let us see at the sensory nerve supply as well. Okay. You can use this image to look at the sensory nerve supply as well. In front of auricle, mainly you have the fifth, that is a trigeminal nerve, which is sensory, not motor. Motor, I already told you, and if I ask you, you can answer it in your heads, which was the motor nerve, the seventh cranial nerve, supplying occipital filter. Sensory nerve in front of auricle is basically branches of trigeminal. All V1, V2, V3. V1 will give supratrochlear supraorbital nerve. V2 will give zygomaticotemporal. V3 will give auriculotemporal. Behind the auricle, we have the branches which are mainly coming from the cervical plexus. So behind the auricle, we have cervical plexus. C1, not C1 because C1 has no sensory supply, but yeah, C2, C3, C4, they will give. And those are known as lesser occipital nerve, greater occipital nerve, third occipital nerve. They are basically C2, C3, and a bit of C4 also might go in the lower part of the skull. These are the sensory nerves. I repeat again, fifth nerve and cervical plexus. Arteries, internal carotid, more anterior than external carotid branches. Okay, do remember this. Okay, let us see more images over here. Okay, here we see. This was a dissected specimen from an atlas. It is showing us all the layers. So let us see it here also. Again, this is skin over here. This is the connective tissue layer. Beneath it, you have this aponeurotic layer. These are the muscles, frontalis and occipitalis behind. This is the loose areolar tissue layer. And then we have this pericranium, which is covering the bone over here. Okay, this is already have seen. This is the trigeminal sensory map. We normally read it. Basically, it is again obviously sensory map showing us the nerve supply or sensory nerve supply of not just the scalp but also of the face and the scalp over here. So here you can see this is V1 area, this is V2 area, this is V3 area. And behind you are seeing the C2, C3, C2, C3, and finally you have the C4, 3, 4, and 5. So behind the auricle, as we discussed, we have cervical plexus. So another way to see it. Okay, black eye we already have seen. Okay, this was the showing us the emissary vein and why that layer is known as a dangerous layer. What was that layer? That dangerous layer was our loose areolar, right? And what is this being shown over here? Again, very important clinical. This is known as gaping of wound. What is known as gaping of wound? So, as we discuss the layers S, C, A, L, and P. Suppose there is a cut, there is an incisional wound or knife injury, could be anything. So suppose the cut has cut along the skin and connective tissue, right? These two layers are cut fine. They will not be gaping. See, gaping, when we use the word gaping, we actually mean that over here, you can see that the margins of the cut over here, you can see this gap in between. There's this gap. Okay, this gaping has done. It's not that a part of the scalp has been removed. No, a simple cut and then there's gaping. So let me tell you in a different way. See, this is the say understand the scalp from anterior to posterior. Okay, if this is the scalp, and then try to understand that this is the muscle frontalis and muscle occipitalis, and this is the direction of the aponeurotic fibers. Okay, now see, if the cut is longitudinal, if the cut is longitude in this direction, then there will be less gaping because this is the direction of the muscle fibers, aponeurotic fibers. But if the cut, but if the cut is, I hope you got the point, is transverse in this direction, then there will be, so the cut is in this direction, then there will be contraction of the muscle. This transverse or perpendicular cut, this will lead to gaping. So the cut has to reach the aponeurotic layer first of all, at least, and the cut has to be perpendicular to the long axis, perpendicular to the long axis of muscle fibers. Basically, it should be transverse. Simple words, it should not be in a anterior posterior direction. It should be in a transverse direction so that there will be gaping. There will be gaping as shown. The gaping movement. If you are seeing a gaping, suppose you are in casualty, you are seeing a person with the injuries coming like this, then you are sure that the cut has at least reached aponeurotic. It might go to loose areolar, it might damage the skull, fracture might there, might not be. There's a different thing. But you are sure that this injury has at least cut through the aponeurotic layer for sure. And that also direction will also tell you. This is a good hint. Okay. And you've already seen this image, right? Okay, let's come back to our notes over here and see if anything is left over. So these are the arteries. Okay. And venous drainage also similar. So we have some veins over here. I'll show you another image of the veins, but do remember that supratrochlear, supraorbital veins, both of these veins, they form an angular vein. Angular vein means around the angle of the eye, this medial angle of the eye, right? And then they form the facial vein we'll see in the face, which form the deep facial, and they ultimately go to which vein? All of them ultimately go to internal jugular vein. That is the point. Okay. Then the other veins, which temporal occipital vein, fine. Lymphatic drainage of the scalp is also important clinically. Why? Because patients do come normally of the lower socioeconomic strata, small children, because skin has a lot of sebaceous glands. Therefore, small children who are not keeping hygiene as their top priority, for small children, their top priority is playing, right? And eating and sleeping. That is the top priority. So hygiene is the second top, is the top priority of their parents, right? But so in low socioeconomic strata, hygiene may not be so be seen in small children. So there are a lot of sebaceous cyst which easily develop. Okay, there are a lot of furuncles, abscess which might develop in the skin. So that infection can obviously involve the lymph nodes, leading to enlarged lymph nodes. So we should know as clinically which lymph nodes to see. So anterior part of the scalp, look for the preauricular. So feel the lymph nodes over here, preauricular and parotid lymph nodes. If there's a more of this infection in this part, feel for the lymph nodes over here. The posterior part of the scalp, feel for the lymph nodes in the postauricular or mastoid region over here. Okay, look for the lymph nodes over here. That is the only point for the lymph nodes. Nerve supply scalp, I guess we already have done. Motor nerve supply, I mean, again, I'm saying basically it is a facial nerve, and sensory nerve supply in front of auricle, behind the auricle, that we already have seen. Okay, I guess today we are maximally using the word auricle, right? Okay, so yeah, okay, the answers are given over here, but don't worry. Read it. So, man of about 30 years of age comes to OPD with the inability to close his left eye. Not able to close the left eye, right? Tears overflowing on the left cheek and saliva dribbling from his left angle of mouth. I'm sure most of you must be knowing the Bell's palsy. Okay, it is basically the palsy involving the seventh cranial nerve. Okay, it's idiopathic palsy. Etiology, some say it's a viral exanthem, it's something else, but yeah, normally single etiology is hard to say. But yeah, Bell's palsy is the idiopathic lower motor neuron palsy for the facial nerve. The facial nerve supplies all the facial muscles. So when we close the eye tightly like this, suppose there's a dust which is you're walking out, there's a lot of wind and the dust is coming into your eyes, you tightly close your eyes. This tight closure of eyes is done by the muscles around the orbit. That is your orbicularis oculi. All the facial muscles supplied by facial nerve. So if there is a facial nerve palsy, then you can't close the eyes tight. Then you have this eyelids will be open. They or at least they will be partially open. Now, when they are partially open, there's a lot of irritation to the cornea sclera, so there will be reflex tear formation, and that tear will be flowing into your left cheek because eyes are not able to close. Okay, so that is a feature of Bell's palsy. Infection in dangerous area of face usually leads to cavernous. We'll see it, right? That's an early bird question, but you'll see it. Cavernous, how the cavernous sinus is linked to the facial veins. Supraorbital artery, I hope you know by it by now. It's a branch of ophthalmic. Now, if ophthalmic was not in the option, then you can go with internal carotid artery because ophthalmic artery is a branch of internal carotid artery. Remember that. Sometimes the examiner might confuse in this way also, right? Also, which of the following nerves ascend along with the occipital artery in the scalp? So, which nerve? Okay, occipital artery is right. Going through the occipital, we have postauricular and occipital artery. So, along with that, you normally have the greater occipital nerve, which goes along with the occipital artery. Just remember this point over here. Okay. Clinical anatomy, I guess most of that we already have done. Wounds of the scalp, sebaceous bleeding, cephalometoma, dangerous area of scalp, all that we already have covered. I'll show you some images as well. Fair enough. So let's now come to the topic of face. Face over here. What are the things that we are going to learn in face? See, face, go from the basics. First of all, in your mind, think about the osteology of the face. So what are the various openings in the, if you look at the skull, okay, the bony skull along with the mandible, what are the openings that you see? You see the opening, orbital opening, nasal opening, and with the mandible, you see a oral opening. On the sides, you see a external acoustic means. These are all the openings. Now, face will have these openings. They have structures inside it, around it. Then in face, it's very interesting that we talk of a lot of muscles known as facial muscles. Okay, there are a lot of facial muscles, right? Normally, questions do come that, or in Viva, they might ask you that, what is the function of the facial muscle? The first reflex answer that comes out or pops out from anybody's mind is, okay, sir, facial muscle. It is a muscle for facial expression. Totally correct, right? Facial expression, sad face, happy face, joyful face, serious face, anxiety face, or shocking face. There's that lot of facial expressions are there. But now there is a small catch over here. I want to tell you that facial expression is not a very important and there's a important part of the human body that it should be there, else we might miss out on something. So facial expression is there, no doubt, but do you think that there will be so complicated muscles just for showing you a happy or a sad face in a time when people are making faces and they are acting doing acting or just doing it in a false manner? So then what is the main role of facial muscles? As we said that there are a lot of openings over here. So these facial muscles, they mainly act as sphincters and dilators, or mainly act as sphincters. Some muscles will also act as dilators for this facial bony openings. Meaning by you have this whole group of muscles around the oral cavity known as orbicularis oris. Okay, you have a lot of muscles. You have levator muscles, depressor muscles, risorius muscle, all that. You have a lot of muscles around the orbit, as we discussed, the orbicularis oculi, and surrounding it, like procerus, you have corrugator supus, lysovany muscles. Similarly, you have muscles around the nasal opening, around the auricle now. As I said, that this auricle is muscles over there. If you look at the general animals like say cow, or say for example, if you look at an elephant, right? Suppose you go to zoo or you watch on a TV, an elephant has huge ears, huge ears. They can move their ears like this. And if you go close to the elephant, you'll see a lot of vessels. You can palpate those vessels over there, right? On the ear. It is also for heat. So you have facial openings, and these are all the muscles which are surrounding that. This thing you should know. Then another important part that you need to know in face, along with all of this, is there any dangerous area of face, as you've seen a question also, right? Yes, there is. The center part of the face, the upper lip, the lower part of the nose, and the surrounding area. This is the dangerous part of the face. Why? Because infections from here will directly reach cavernous sinus, leading to cavernous sinus thrombosis. I guess that was the question. These are the three, four things that we are going to see mainly. So let's see over here. So facial muscles are subcutaneous muscles. Embryology, they are telling it's a mesoderm of second branchial arch. Therefore, do remember what is the nerve of second arch? The nerve of second arch is seventh cranial nerve. Therefore, facial nerve and facial muscle. Normally, seventh cranial nerve derived its name facial nerve because it is supplying all the facial muscles. Now, here I want to tell you one more thing. So I am sure some of you might be knowing that when we use the word facial muscles, we don't include the masticatory muscles in facial muscles. I repeat, we don't include the masticatory muscles in facial muscles. Now, what are the masticatory muscles? Mainly four: masseter, temporalis, and two pterygoid, medial and lateral. These are not a part of facial muscles. These are masticatory muscles. These are supplied by mandibular nerve, not the facial. Okay, I hope the point is clear. So coming back to this point, embryology, second branchial arch. Morphology is the remnant of panniculus carnosus. Fine. Have a look at the facial muscles. Now, see over here. Do you think that all this artwork the creator will do just to show a happy or a sad face? I doubt seriously. So you can see a lot of muscles around mouth, lot of muscles, group of muscles around the eye opening, lot of muscles around nasal opening. And if you look at the side view, not much in humans. We have a lot of muscles around the auricular or the ear opening. Remember that. We'll come to the muscles also. So few basic muscles are over here. Muscles of facial expression. You should basically at least if the image comes, you should basically identify which muscle is over there. At least this much. Origin insertion, I doubt they will ask you. If they ask, it's a bit of difficult question for sure. but not actually needed. So not needed means don't go into details of it. Only when you have completed everything, just for the sake of learning, you can read it. As buccinator muscle is present where? Over here for the cheeks. It compresses the cheeks. Now see the name of the muscles. Depressor labii inferioris. Depressor means, okay, you pull the face down, depressing look. Labii means lip, inferior means lower lip. So it will pull the lower lip, it depresses the lower lip like this. Okay. Levator labii superioris. It will elevate the upper lip. Okay, it will elevate the upper lip. Superioris labii means upper lip. Levator means elevate. Mentalis, this is the area for the mental symphysis, mental protuberance. So elevates and protrudes the lower lip close to it. Orbicularis oris, mouth. Okay, closing the mouth like this, compresses or purses the lips. Rhizorius right over here. I show you another image also, don't worry. It draws corner of the mouth to the side. Depressor anguli oris. It will depress the angle of the mouth. Corner. These are the angle of the mouth, corners of the mouth. It will depress like this. Zygomaticus major, zygomaticus minor. They are basically for laughing muscles, right? We'll see what are they mainly made up of, or what are the for function. I we have levator labii superioris. This is not shown. Now let me add over here that this is actually learned along with the extraocular muscle, and it is supplied by third cranial nerve, not by the seventh nerve. Remember this. Orbicularis oculi, it showed you, I told you, it closes the eye. Nose, we have procerus, and then we have nasalis. Ear, scalp, we have already seen. Neck, we will see this platysma muscle, right? Okay, let me show you the muscles for face directly over here. Okay, just give me 1 second. Okay. Okay, we'll see, come to this image, but first of all, let us look at the muscles of the face. I'll tell you all in detail. We'll stick to this only. Okay, over here, over here. So identify a few muscles over here. Okay. For example, orbicularis oculi must to be known. The zygomaticus major and minor. Remember, when you laugh, it happens like this, no? You have this elevation of the lip over here. So these muscles, they help in basically laughing or smiling face. Levator labii superioris, name it's self-sufficient. Rhizorius C. The whole group of orbicularis oris. Okay, whole group over here. Then depressor anguli oris. Okay, buccinator for the cheeks. Corrugator supercilii, same images also, like frowning action over here. And this over here is a platysma muscle. This muscle, no? When you do like this, and we for males basically, when you are doing a shaving, you try to make this area tight, that when you're shaving with the blade over here, it doesn't cut your skin, right? So you do like this, no? So that this area, that pulling of the skin is done by this platysma muscle. Okay, just remember that. Okay. Okay, let us come from this part only. Let me teach you first from here only, then we'll come to the notes part. Just let us give few minutes over here. So what has been shown over here? This is all the sensory nerve supply of face. This is a beautiful image, and all the nerves are shown. You have to understand basically that V1, V2, and V3, all of these three, as you have seen in that trigeminal sensory nerve. So it's basically the trigeminal nerve. It is basically the trigeminal nerve, which is the sensory nerve of the face, and it is the facial nerve, which is the motor nerve of the face. Please remember it. Okay, please remember it. So in facial palsy, what will happen? The face will not move. The facial muscles will be paralyzed. Sensation will be there. Diseases are there, no? For facial nerve, I'm telling you, we have facial palsy. That is your Bell's palsy, right? Most commonly, your Bell's palsy. Applied Bell's palsy. See, I'm again telling you, anatomy is one of the most interesting subject that you will encounter. Some of you might be seeing like this. So what you are saying, sir? But I'm telling you why. Everything what you read, think of its clinical counterpart. Then the things become very interesting. So Bell's palsy, a facial nerve problem. Trigeminal nerve is a sensory nerve. You have a very common condition known as trigeminal neuralgia, where you're severe pain. Patient says, when I brush my teeth, there's severe pain. When I comb my hair, severe pain. Okay, so that is trigeminal nerve involvement. So trigeminal nerve is sensory nerve. Now, one area of the face which is not supplied by trigeminal, and that is a very, very famous question, is this area. Can you see the C2, C3? The C2, C3, that is our great auricular nerve. Great auricular nerve, it supplies the area around the angle of mandible, the parotid region over here. So C2, C3, great auricular, it supplies the region around the angle of mandible. Suppose someone asks you, okay, you're telling that trigeminal nerve is the entire sensory nerve of face. Which part of the face is not supplied by trigeminal nerve? Then you will answer, sir, it is the area around the angle of mandible because that is innervated by great auricular. Okay, that will fetch you good marks. Here we're looking at the lateral side, mainly you're looking at the arterial supply, as you can easily see from the diagram. Main artery over here, which you need to know. Okay, so main artery over here, or main artery which supplies the face per se is the external carotid artery. Is which artery? It is the external carotid artery. Couple of branches over it, or main branch which supply the face over here is basically it is the facial artery. This facial artery is a tortuous vessel. It is a tortuous vessel. Identify the facial artery over here. Let me move this area from here to here. Okay, right. So here we have this being our facial artery. And I want all of you to at least palpate in the lower border of mandible over here. If you clench your teeth, you will feel the masseter muscle, right? This is the masseter muscle, right at the anterior inferior angle of the masseter muscle over here. Try to palpate against the mandible. You might feel the pulsation of this artery, facial artery. It's a tortuous vessel and it's give off a lot of branches like inferior labial, superior labial, lateral nasal. These are the main branches and angular artery. They supply the face. Other artery, as I told you, can palpate over here in front of ear is the superficial temporal artery over here. This is again a branch of ECA, facial also a branch of ECA. So main artery supplying the face is ECA. Only this front of the scalp or forehead part, we have the supratrochlear supraorbital we have seen in the scalp that is coming from ICA branch of ophthalmic medulla. Okay, remember this. Facial artery is tortuous artery. Why? Because when you close and open the mouth over here while you're eating anything, this artery should not be stretched. So it is made tortuous over here. Then let us see another similar image over here. Okay. In this image, artery is shown. You can see the facial artery over here. Let me change the color so you easily identified. Okay, right over here. Right, so facial artery over here. But artery we already have seen. Now look at the facial vein over here. Look at the facial vein. It is a vein which is going behind the facial artery, so it is not that much tortuous. Okay, artery is tortuous more anteriorly, but vein is not. You can see the facial vein going in this direction, right? This is the facial vein. We'll see other connections. As it goes down, it joins with the anterior branch of retromandibular. Which vein is this? This is retromandibular vein. Okay, so it is just behind the mandible. It is retromandibular vein. It gives off an anterior division anteriorly and obviously a posterior division. So this anterior division of retromandibular, it is joined by the facial vein, and these both they form the common facial vein. So facial vein plus anterior part of retromandibular vein, they form what? They form the deep or they form the common facial, not the deep, but the common facial vein. CFV, common facial vein over here. Now this common facial vein is the one that is going to drain into internal jugular vein. Where, sir? You can see this common facial vein, it is going down and you can see this internal jugular vein. Okay, now coming to deep facial vein, as I just said a word of deep facial vein, what actually happens is now look at the upper part of the facial vein, this area. Okay, we have this deep facial vein over here, which will go from facial vein to this plexus. What is this? This is pterygoid venous plexus. What is this? This is pterygoid venous plexus. Pterygoid venous plexus. And from pterygoid venous plexus, the veins are communicating to this is CS cavernous sinus. So let me put some red dots over the cavernous sinus so that you identify it as a serious case. What is happening again? I'm telling the facial vein via deep facial vein goes to pterygoid venous plexus over here, and from here they communicate with the cavernous. Around the orbit, the facial vein communicates via cavernous sinus directly through this orbital, or you can say superior ophthalmic vein, not superior and inferior ophthalmic vein. So we have superior and inferior ophthalmic veins. So they also communicate directly with the cavernous. Therefore, that was the point why we said, okay, that this area is the dangerous area of face. Because here the venous drainage is directly or indirectly going where into the cavernous sinus. And therefore, cavernous sinus can be blocked, leading to cavernous sinus thrombosis. Cavernous sinus can be blocked into cavernous sinus thrombosis. Let us see more over here. This is the dangerous area of face. This image is showing us the dangerous area of face. Now, what is the relevance of this clinically understand? See, if you see a patient or in your friend, family, relatives, wherever, there are, small furuncles over here, small pimples or whatever it is, and people all the time they do this and that experiment, and nowadays they look a small video, reel or shorts, and they do something instrumentation over there. Ask them to, okay, don't squeeze this area. Don't squeeze this area if you are having any infection. Because squeezing this area and this facial veins which you have seen, they are volvulus veins. They don't have any valve. So you can apply creams, you can take some antibiotics, you are facing infection, but don't squeeze them harder if there's infection over there, because that may directly or indirectly block the cavernous sinus, leading to cavernous sinus thrombosis. This is again an image showing us the superior ophthalmic vein. Focus on this vein, then focus on inferior ophthalmic vein, and focus on cavernous sinus. How these two veins they are going to cavernous sinus. Then, as we said, we focus on the deep facial vein. This is an indirect route. Focus on pterygoid venous plexus over here, and how it is reaching the cavernous sinus. The main point is this cavernous sinus thrombosis. And this is the anatomy of cavernous sinus. Why cavernous sinus? We will study in detail, but this is a coronal section of cavernous sinus. The problem over here is that the cavernous sinus is having a lot of nerves in the lateral wall, like third nerve, fourth nerve, V1 and V2 also, and also sixth nerve over here. It is also having the internal carotid artery inside. So if this part becomes blocked, then all these nerves and this artery, they start to get compressed. Plus veins are already blocked. So let me give you a overall fair enough idea what will happen in case of cavernous sinus blockage. See, sinus is venous sinus now. So obviously the veins are blocked. Okay, so there will be congestion in the eye. Then third, fourth, sixth nerve are blocked. So eye will not move. There will be ophthalmoplegia. V1, V2 will be compressed, mainly V1. So there will be pain in the eye because V1 was sensory. Sensory. If IC is also getting involved, then there can be development of fistula between the artery in a vein. So imagine eyes are congested, it is painful, eyes not moving, condition somewhat happens like this. Not a good picture to see. But you can see congested eye, painful eye, and unable to move eye. Other features of bilateral condition starts on one side, can reach bilateral. There are muscles which you already have seen. So we have seen the sensory nerve supply and all that artery and vein. This is the motor nerve supply. Now, motor, you just can't remember facial nerve. It will have branches which are shown over here. Okay, branches like you have the uh, various branches like temporal branches you have, like zygomatic branches you have. Okay, then you have the buccal branches you have, then we have marginal mandibular branches we have, and then we have the cervical branches we have. So let me tell you how to remember it. So there are various mnemonics like 10 zebras, bite my cat, and something like that. But depending on the area. See, I'm not a big fan of mnemonic, nor I would like all of you guys to be a big fan of mnemonic. Use mnemonics wherever it is helpful to you, and use them with some good justification. Else you will only remember the mnemonic in the exam. So suppose someone asks you all of a sudden out of blue that, okay, tell me the branches of facial nerve on the face. You have 5 branches like this, which we remember, no? How do you tell? So see, one is going upward. Which bone is over here? It is a temporal bone. So say we have a temporal branch. Okay. Then what is this bone? Zygomatic bone, right? Prominence of cheek. Okay. Then we have a zygomatic branch. Then this is the cheek area. So we have a buccal branch. 4 or 5 times you will read the names, it will automatically come to you. Then below the cheek, what do we have? This mandible. So we have nerve running on the margin of mandible. We call it as marginal mandibular branch. Then going to the neck area, cervical branch. Simple as that. Okay, it's not a rocket science. Okay, simple as that. Okay, these are all the muscles with their facial expression. I will show you more in the notes as well. So, frontalis, see over a frontalis, right? Horizontal, wrinkling over the forehead. Orbicularis oris, okay? Mentalis, depressor anguli oris, zygomaticus major, laughing face, rhizorius, okay, angles of mouth, corrugator supercilii, or the vertical wrinkles and the medial side of forehead, nasalis, dilator of the nasal opening, proceedus again for the nose and the forehead part. Okay. So this is all about the face. Now let us quickly go through the notes and see if there's any potential part over here. So these are the muscles opening in the face. You already have seen cutaneous nerves in the face. We have seen them in details. Okay, remember that diagram. Okay, that diagram. Understand from there. Now supply the face motor. Okay, so temporal, zygomatic, buccal, marginal mandibular, and then we have fifth one cervical nerve also. Okay, sensory V1, V2, V3 we have. Okay, the mnemonic of they have written two zebras. Okay, I said 10. Okay, two zebras or 10 zebras. Bite my cat or befriended my cat. Okay, fine. Sensory nerves, you already have seen the image. Examination facial nerve, yes, that is important. So if Bell's palsy is quite common, how do you examine the facial nerve? Ask the patient to look is to face should be straight but look up. So if your face if you're not moving your neck and you're looking up and you're really forehead wrinkles, you are looking at a frontalis muscle. Okay, that's how you can check. Then ask the patient to okay fill air inside your oral cavity. Okay, and ask them to hold it tightly. If the facial nerve is not working, then buccinator muscle will be paralyzed. Then they will do like this. Air will leak out. You'll try to hold the air. Okay, try to make a balloon inside the oral cavity. But it won't be possible. Air will leak out like this. Okay. So okay, we can ask them showing the teeth. Okay, tight closure of the eye. There are so many. Every muscle you can basically ask them. So these 3, 4 easily tests you can do. Okay. So how to again test the facial nerve? We look that in the detail of facial nerve because facial nerve gives off a branch known as cauda tympani nerve, which is sensory to the or just for taste sensation from the anterior two-third of the tongue. So if you place some sugar or salt in the anterior part of the tongue and ask them what is the taste, and if they can't tell you, you know that there's a problem in the at least in the cauda tympani nerve. Then muscle facial expression. See, raising the eyebrows. Now this can come as a good question, not just for university level. University level you can write, but also for the PG level. So raising the eyebrows, frontalis, you're testing. They can give an image-based question like this over here. Frowning, corrugator supercilii. What is happening over here? Let me tell you. You have this vertical furrows over here. Frontalis, you have the horizontal lines over here. Okay, wrinkling of the nose. That is mainly a deal of both procerus and nasalis. Okay. Lessons of facial nerve, yeah. Upper motor, lower motor. This will read in detail when you do the facial nerve part, right? Facial vein we have seen where it is draining, dangerous area of face we have done, cavernous sinus thrombosis we have seen. Okay, let us do a couple of MCQs over here without looking at answers. So dangerous area of face is named because of connection of cavernous sinus with facial vein. Through which vein? What was the joining vein? So there were superior ophthalmic veins. Let us revise all of them. There was inferior ophthalmic vein. There was a deep facial vein, and there was pterygoid venous plexus. See, out of these 4 options, what we have deep facial vein. Infection in dangerous area of face usually leads to, okay, that is okay, cavernous sinus thrombosis should be DNC over here, DNC over here, right? So guys, this was about our scalp and face. I hope you guys enjoyed. Any query? Ask them in the comment box, right? And that's so that was all. And follow us on the social media handles. That's all from my side. I'm Dr. Ankit. See you soon. Till the time you revise, and if there are any doubts, do let us know. Okay, so that's all. Thank you and bye bye.